Okay, we'll move along. The next session is by Robert Whitaker, Autonomy of a Global Epidemic, Psychiatric Drugs and the Rise in Disability. I think that most of you don't need much of an introduction when it comes to Robert Whitaker, but let me just say that he's a journalist and an author that has won numerous awards for science writing. He's written 3 books which cover the practice of modern psychiatry, among them the Anatomy of an Epidemic, which was published in Norwegian by Abstrakt Forlag in 2014 with the title En psykiatrisk epidemi. Autonomy of Epidemic won the prestigious Investigative Reporters and Editors Book Award for Best Investigative Journalism in 2010. Bob is also the founder and publisher of Mad in America, a website critical of modern psychiatric establishment that has gone global with a growing number of websites in different countries around the world. And soon it will also come to Norway as Mad in Norway. So, Bob, it's a pleasure to again give you the floor here in Oslo.
I just want to say it's a real pleasure and an honor to be here. I'm not sure how many times I've been in Norway, but it's great to be here. First, I just want to give a shout out to Einar. I think you're very lucky to have Einar here to constantly be struggling to bring forth books and information. I think if without Einar, the Norwegian debate and the Norwegian discussion wouldn't be nearly as robust. So well done and thank you. I half feel just like talking now. That film was great. The film was so well told. And basically, you saw in the film the story that's in the data. So what the data shows, and we'll go through some of this, but nothing can be as powerful as a story like that. The story that shows up since 1987 in country after country is that one of the roots to disability and to becoming a chronic patient is you take someone when they're 17 or 18 or 19 or 20 years old and they have some sort of depression or anxiety, whatever the minor problem is that often comes with life at that time and can come with life at any time. They go into a psychiatrist, they get put on a drug, and then 10 years later, you see this downhill course where you see someone move from an episodic problem, a moderate problem that would have cleared up, and next thing you know, they've been on 20 drugs, they've moved to a more serious diagnosis, and they're now seen as a chronic patient. Now, there's a number of people that, not enough, but there are many stories out there of people who've gone down this horrible, horrible slide, lost years of their life, been seen as chronically mentally ill, and then sort of like, how do you pronounce your name, Silje?
My name?
No, the name of your character.
Celia.
Then basically they get their life back when they come off medications. But so many people never get the person that helps them stir them to come off medications. I'll go through this data, but when you see this story, you're struck anew about the tragedy here and the loss of life in taking a healthy young person and turning them into a chronic patient. That's what happened. It's so clear, right? And does anybody doubt that, what you just saw here? That's what you saw. The other thing, most of you probably have heard of Peter Gotye before. He's the doctor where she goes and travels to Copenhagen to say, what do you see of this? And he goes, well, your life is a catastrophe. Well, his life is a bit of a catastrophe now because of his speaking out against psychiatry and writing about this. He got sacked from his job. You know, sacked, it means you get fired. And he even got pushed out of the Cochrane Center. I actually was with Peter a couple of days ago. We were at a conference, which in this case I actually helped organize, on a psychiatric drug withdrawal. And one of the good things that I think is happening, and then we had people from 13 countries, although the largest contingent was indeed from Norway. You should be proud of that. It's putting this idea that it's time to put psychiatric drug withdrawal into the media, into the public discussion, and see the possible benefits from that. And by the way, I was talking to Einar today. Is Jan Hammer here by any chance? Ah, there you are. You're also lucky in Norway. I mean, you have so many good things happening here. You have, you know, the medication-free ward initiative. You have the recovery hospital. But you also, and I was telling Einar this, is it Vestre Viken where you work? Yeah. They've been doing something for 20 years where they've been working with chronic, people who are seen as chronic, people who are seen as treatment resistant, and they developed something called basal exposure therapy. And not too long ago, you published your, was it 5-year results, Jan, of the first 35? And if I miss, this is in my memory, if I have it wrong, you correct me. Of the 35, now these were seen as chronic, chronic patients, treatment resistant. I believe 15 were off meds at the end of, was that right? And of the 15, 8 were basically asymptomatic. They're back, they got their lives back. Do I have that right? That's the only research I know since the introduction of antipsychotics that tells of people, working with people who've been seen as chronically ill for a number of years, and now we're going to do an effort to get them off medication and see what happens. That's the first publication I really know of that possibility of how taking people off can restore people to life, even those seen as basically the most troubled in the hospital. Is that right? Anyway, what I'm trying to say is you're lucky here in Norway. You're entering it's on a societal level, you're having a discussion that is not happening in many other countries. The one thing, did you notice at the end of the movie where the book contract gets canceled? You all saw that? You all saw that? This tells about how hard it is to get into the public domain, this story of people who've been harmed by psychiatry and then get better once they leave it. Apparently the book publisher didn't really want to tell the story of, a catastrophe. But that's great you're telling that story. It's really so important. I've never felt that the data can be so anticlimactic after that. Anyway, just what I'm going to show you is anatomy of an epidemic. I just looked at this question. In 1987, we get Prozac. And that, of course, as you saw in the movie as well, it was heralded as this great new drug, this breakthrough new drug. It could make you better than well. And it's that marketing message, that story that kicked off this great explosion in the use of psychiatric drugs and the great explosion in diagnosis as well. Now, generally, when you get new medications that are supposed to be so great for a disease, you won't see the rise in the burden of that disorder rise, right? You'll see the burden of that disorder go down in society as more people get effective treatment. Anyway, this is just the first part of this. This just shows in the United States this extraordinary expansion in spending on mental health since the arrival of Prozac. This is total spending. This is spending on psychiatric drugs, more than $50 billion. And what has happened? Prozac comes in at this time. At that time we had, and this is per capita, per 100,000, 543 people disabled per 100,000 population. Now where were we in 2010? 1,600. You can see this is about a 3-fold increase in the disability rate over this period of 23 years. It's even grown up a bit more. Just in absolute numbers, we had 1.25 million adults on disability in 1987. We're now around 5 billion adults today. So we saw a story of one person. We're talking about millions in this data. By the way, when I was in Skien, am I pronouncing that right? Skien yesterday? Skien. I got some data on Norway's disability rate due to psychiatric disorder. And what I was told that 36% of all disability cases in Norway are now due to psychiatric disorders. And if you look at the numbers, your per capita rate of disability due to psychiatric disorders is higher than in the United States. Which one reason that is surprising is, for me, is your society is not as screwed up as ours is in terms of social inequality and poverty. So it's really a little stunning to see that rate of disability. The other thing that has happened since this time is we didn't used to medicate kids really until the late 80s. In 1987, there was something like 16,000 kids in the United States on disability due to psychiatric disorders. Then we start giving them stimulants, then we start giving them antidepressants. Around here, we start giving them antipsychotics, and what has happened? You just see the number of kids on disability due to psychiatric disorders has soared. We now have 800,000 children roughly receiving disability payments because they're disabled by, obviously it's their parents or guardians who receive the money because of a psychiatric disorder. Do you know what happens to these kids at age 18? Any guesses? They go on to adult disability. Sorry, I've got this cold. They go on to adult disability. So what you see in this data is a story of how you can diagnose kids and turn them into lifelong patients. That's what this data is talking about. Roughly 2/3 go on to adult disability and never work. I was asked, the data here is a little bit scattered, and part of the reason is it was developed for different purposes. A few years ago, I was asked to give a presentation to a parliamentary work group in the United Kingdom on the rising disability of mood disorders. If you want to see where the big driver in the United States is, it's not so much psychotic disorders, it's mood disorders, it's depression and bipolar. And so what I did is just look on, as much as possible, number one government disability due to mood disorders and the corresponding rise of the correlation in terms of increase of antidepressants. And what you'll see here, from 1994 to 2013, there's like a 5-fold increase on disability due to mood disorders. And you see this 5-fold increase in the use of antidepressants. So, of course, the question is, which is the chicken and which is the egg? And then we'll get to this. In other words, are we seeing this rise in antidepressants because of a rise in mood disorders? Or are we seeing a rise in disability because people are using antidepressants for mild disorder and then they're getting pushed onto disability? I'll let you get it. You know what the answer is. There's no rise in the percentage of the population from this time to this time that was suffering from a mood disorder. What was different was the percentage of people treated for it with drugs. So I looked in other countries, and what you see over and over again is that as antidepressants are marketed to a country, the number of people on disability goes up almost in step-like fashion. That's the UK. This is Australia. You'll see that they've had a 5-fold increase in disability in 20 years. They went from almost no antidepressant use to 10%. By the way, these numbers are now above 10% in terms of the number of population using this. This is Denmark. This is a little bit different data. So these are the total number of people on disability. This is percentage used. This is the number of new cases of new people going on disability each year in Denmark. You'll see it more than double between 2000 and 2010. This isn't the cumulative number of new cases. What do you see? Rise in antidepressant use. This is Iceland. Now this is really interesting. You see where this takes off? 1999, right? So there's really not much growth in the number of new cases of disability each year up until 1999, 2001. See if I can go earlier. But in Australia, it was starting in 1991. So why would Iceland be later? It's very simple. Iceland's a small country. When they were marketing antidepressants, they went after the big countries first. So you don't get the marketing of antidepressants, the pushing for it, until here, and that's when you get this rise in the use of antidepressants. Iceland now has, I'm sure most of you have been to Iceland, beautiful country. They have the highest disability rate, I think, now in the world due to mood disorders. This is Sweden, and again, this is a little bit different data, and what it's showing that if you look at all the cases of disability, which might be musculoskeletal and whatever it might be, in 2000 it was like 24% of the cases. Now 60% of the new cases in disability in Sweden are due to psychiatric cases. So that's the disability data. Now when I first published Anatomy of an Epidemic, here was the response. The reason disability is rising so much in the United States is our country sucks. And we don't have a welfare system, we don't have a social service system, and people are going on disability just because they're poor. There's a tiny element of that, frankly. But, and people said, oh, I bet you're not seeing that in the Scandinavian countries. But it's happening in every country that adopts this paradigm of care and widespread use of antidepressants. And by the way, when we're going to end on a study that just came out today in the British Medical Journal. It's the British Medical Journal Evidence-Based Medicine, and you'll see the latest conclusion by international researchers about the use of antidepressants. Okay, real quickly. Although disability due to psychotic disorders really isn't increasing all that much, what we do now have is a lot of research, an increasing number of long-term studies that show that recovery rates and functional recovery rates are better for unmedicated patients if you have a diagnosis of psychosis or schizophrenia. This study here is the best long-term study ever done, done in modern times by in the United States. It was a naturalistic study done by Martin Harrow at the University of Illinois. What happened is people came into two hospitals, one private, one public. They were all treated with drugs. They're discharged, and now they're just going to follow them for the next, actually he's now up to 25 years. He's going to follow them up at 2 years, 4.5 years, 7.5 years, 10, 15, 20, and 25. And each one he's going to see, are they taking medications? Are they asymptomatic? In other words, are they psychotic or not? Are they working? Do they have a good social life? And to be in recovery, you had to be both asymptomatic and working or in school at least 50% of the time and have a decent social life. His hypothesis was that those schizophrenia patients who go off medication will do poorly. He expects to confirm conventional wisdom. Now, by year 2, there were two groups really. There was a schizophrenia group and a milder psychotic disorders group. We're just going to focus on schizophrenia group. By year 2, I think 25 of the 64 were off medication. And you'll see, okay, there's a little bit higher recovery rate, right? Now what happens between year 2 and 4.5? Because you don't see this in any other place in the research literature. What happens is, these people are off, but they're really not much better. But what happens is you see a recovery happening between year 2 and 4.5, whereas these people don't get any better. Okay? They're not recovering. And this is the only place you see in this research literature which talks of longer-term recovery that takes time. Because what the literature does is you have short-term trials for 6 weeks. That says, that establishes maybe the evidence of the short-term efficacy of antipsychotic drugs. And then long-term data, you know what they do? They take people who stabilized on antipsychotic drugs, and then they randomize. One is abruptly taken off drug, and the other half is maintained on drug. And with great regularity, those abruptly withdrawn from the drug relapse at a higher rate, and they say, see, that's why you have to stay on the drugs long term. But really, all they're measuring is what happens over a short term after you abruptly take people off the meds. But this is what's so great about this. We're seeing the capacity for many people to recover over the long term with time. And by the way, these people are not getting care. These people have left, because you can't, in the United States, if you're not taking drugs, you're probably not going to be getting care if you're diagnosed with schizophrenia. So these people left care. And what he found was psychiatrists didn't see this recovery. The people who left care got better. They didn't go back to their psychiatrist and say, hey, look at me, I'm doing great. So he said, this is the illusion. They don't see the people that are doing well. What I'm going to show you now real quickly, there's been a number of different types of studies in different countries. When you really parse the data, you see over and over again, it's the unmedicated group doing better. This is a study by Wonder Inc. It really was a discontinuation study, or an attempt to get people off down to as low a dose as possible. So it's randomized. After initial stabilization, you're either into the arm where you get a chance to taper or discontinue. The other's conventional care. He looks at 2-year results. And then after 2 years, it becomes a naturalistic study, regardless of whether, which group of randomization you're in. Some people can go back on drugs, some people will stop. So what all I've done here is look at the 7-year results by people who are on drug, that's red, and those off, or even down to a low dose, you'll see better symptom remission, better functional remission, 3 times the recovery rate. And the thing, if you go back to the randomization, the thing was those randomized to the tapering arm were more likely to end up in this discontinued low dose category. This is a Danish study, 10 years. You look at outcomes at 10 years. I'm trying to do this real fast. These were younger kids, first episode, I believe. And you see, once again, these are actually pretty good results in a way. 74% off antipsychotics were in remission, 37% employed. Again, once again, you see more likely to be in remission and more likely to be employed. This is just work outcomes by remission status and medication use. So this means these are people who were asymptomatic and off antipsychotics, and you'll see 43% were employed. These people were asymptomatic but taking drugs, and you'll see only a lower number were employed. Almost as many people still symptomatic but off drugs were as employed as those who were asymptomatic and on drugs. So once again, you see a better functioning here on the whole in the off-med group. This is a study where they just looked at people in northern Finland. They looked at people who had been born in 1966, and at some point by close to the year 2000, they had a diagnosis of schizophrenia. I think the average had been diagnosed maybe in the 20s and that sort of thing. And they're just going to chart. We're going to look at this group of people who got diagnosed, how they're doing at age 34. And you'll see. Those who had stopped taking their medication, much more likely to be in remission, much more likely to be employed, much more likely to be married, and much less likely to be on disability. Okay? So what you're seeing in these different studies from different countries who are looking at this, coming at this from different angles, every time you see that on the whole it's the group off medications that's more likely to be asymptomatic and working. And again, in most of these studies, the people who are off medication, it's not that they've been supported. They've had to leave care in order to make this decision. Now, one of the questions, of course, is if we had a form of care that actually supported people to come off medication, or maybe never put them on in the first place, could you get higher, even better results? And that's the promise of open dialogue therapy as it was developed in northern Finland. And they developed a form of care that's intensive, sort of psychosocial care. I'm sure you all heard about it. But the key thing is, with the first episode, they try to avoid putting people on antipsychotics. And in their 5-year results, here were their 5-year results. They've had this in a couple of things. At the end of 5 years, 80% of their first episode psychotic patients are working or in school and asymptomatic. And in terms of antipsychotic use at the end of 5 years, 67, this is in the data that was presented after the first 10 years. This program began really in 1992. 67% of their first episode patients had never been put on drugs. Another 13% had used them for a time, and only 20% were on antipsychotics regularly. So what you see in that open dialogue program is a way to really you see a couple of things. A way to really maximize results if you don't immediately put everybody on antipsychotics. You try to get them through that first psychotic episode. That's the first, so it's a selective use model. The other thing you see in this, though, let's go back. What is the natural course? If you look at all the first episode psychotic people, is that a chronic course that's sort of predicted, or in fact is it more likely to be an episodic course if you give people intensive care? And what the open dialogue success, as practiced in Northern Finland, is that if you give people this intensive psychosocial care right up front, you can often turn this into an episodic problem. Maybe it's going to last a year, maybe it's going to last 2, but 5 years later, you basically have a recovery rate of 80%. Now, one of the tragedies, in my opinion, that's going on in most countries that are now adopting, trying to adapt or adopt or bring this into their form of care, open dialogue, they're just doing the psychosocial care, but not the selective use of medications. In other words, they're using medications in a conventional way. And I don't think they're going to have nearly as good results because of that. Now, this is just looking at studies in basically Western countries and looking at the recovery rates for people diagnosed with schizophrenia over time. This is before 1941. This is beginning of war. Why? 1955 is when antipsychotics are introduced. You get the Largactil and the first drugs we remember today as antipsychotics. And then this is the first time of using them. Then we get a time when they start talking about the need to maintain people more regularly on the drugs long term. And there's some question about changes in diagnosis a little bit. But look at this. This is the era of the atypicals. It's worse than it's ever been. Those are our outcomes today. All right. So those are the psychotic disorders, and let me just stop for a second. So what story is buried in that data? If you trace the history of research on antipsychotics, here's what you find. There has never been a study of the short-term effectiveness, a good placebo-controlled trial, of the short-term effectiveness of antipsychotics in medication-naive patients. Do you know what that means? Medication-naive means people never exposed to the drugs. So the way even the short-term trials have been done is generally what they'll do is they'll take people in a hospital who are on medications, they'll take everybody off, okay? And they're going to do a couple days of placebo washout. If you start getting better, you won't even be randomized in the trial. But if you don't, if your symptoms get worse because you've been abruptly withdrawn, you're either randomized to placebo or you're put back on drug, which means the short-term literature, the literature on the short-term effectiveness of antipsychotics basically compares people who've been previously exposed to medications, and what it shows is that if you're maintained on those drugs, you're likely to be better than if you were abruptly withdrawn from those drugs. That's the short-term literature. And it was confessed by a psychiatrist at Columbia University a couple years ago. There are no placebo-controlled trials, good placebo-controlled trials, in people who aren't previously medicated. And the reason this is so profound is that you go on an antipsychotic real quickly. What an antipsychotic does, it blocks dopamine receptors in the brain in response to, so you're now thwarting dopamine transmission along these neuronal pathways. It acts as a brake. So what does your brain do? It puts the accelerator down on dopamine transmission, and it increases the density of its dopamine receptors. Researchers say your brain is now in a dopamine supersensitive state. Okay, so now you have your brain like this. Drug acts as a brake. Your brain puts down the accelerator. What happens when you take away the brake? And by the late 70s, they were saying, this is why we may be getting such severe relapses when people come off, because their brain has become accustomed to the brain. God, I'm tired. The brain has been accustomed to the drug. And there was a paper in 1977 that said, is the cure worse than the disease? Are we actually making people more biologically prone to psychosis than they would be in the normal course of their illness? And that was a statement by one of the leading schizophrenia researchers, Will Carpenter, in the country. And what they then did is they figured out, researchers at McGill University said, aha, we think we know why it's so. It's because the drugs cause this dopamine supersensitivity. And I would say all of this data, where you see these poor long-term outcomes, is basically confirming that the drugs are worsening long-term outcomes, including making people more biologically vulnerable to psychosis over the long term. All right, real quickly on the antidepressants, I'm going to just skip to the longer-term studies, just so you know. Before the antidepressant era, which really begins in the 1970s, the understanding of depression was it was an episodic disorder. It will clear up on its own with time, and the idea that antidepressants could help shorten the recovery time. But the thought was, even in hospital patients, 80% will be recovered within at least a year, and the recovery would begin sort of after 1 month. You'd have a certain percentage, 2 months a certain percentage, etc. Then in the 70s, some doctors said, yeah, my patients may be getting better faster, but they're relapsing more frequently. Are we causing a chronification of the disease? In other words, is our treatment making it more likely people will still be depressed years later? And here's some of the studies you can find on this. This is a study done in the Netherlands. So they looked at 222 patients who had a first episode of depression and either treated with drug and then without drug. And then they looked how many of those people then relapsed in the next 10 years. Look at those treated without drug. They had one episode. 76% recovered and only had one episode. Now this is actually pretty good. 50% recovered and only had one episode. But you'll see that the medicated people had more likely to have two episodes, or two or more, or more than two. So what you see here is it seems like they're increasing the biological vulnerability over time to depressive episodes. This was a study where they just looked at medicated people. It's a large study, asked them to keep and these are milder depressed patients. These are not hospitalized patients. Asked them to keep a journal and to see how many weeks are you depressed each year. You'll see those taking antidepressant were almost depressed as twice as often as those not. This is a really interesting study. This was done by the World Health Organization. And it was meant to establish the benefits of screening for depression. So the way it worked was this. Researchers went into, I forget the number of sites in various countries around the world, WHO researchers, and then they acted like flies on the wall. And what they did is they would give tests to people coming in for treatment for whatever it might be, screening tests, and they would identify the people who were also depressed. And then they would wait to see if the general practitioners, and let's say someone came in with a foot ailment, also then noticed whether they were depressed and gave it a diagnosis. And the hypothesis was that those who got diagnosed and treated would be doing better at the end of 1 year. And that would therefore establish the benefit of screening in primary care settings. So what did they find? The people most likely to be depressed, still depressed at the end of 1 year, were those who got diagnosed and treated with antidepressants. The group least likely to be still depressed was diagnosed and no drug. Okay? And even undiagnosed and no drug was about the same. So rather than establish the benefit of screening, do you have screening programs here in Norway? You do, right? The WHO still nevertheless said, let's go screen. This showed that getting treated for depression increased the likelihood you'll still be depressed a year later. And this is really interesting. So you'll see in those who were diagnosed and got treated with antidepressants and diagnosed and didn't, their severity of illness was basically the same at the beginning, right? And their symptoms, their symptoms improve at about the same rate at 3 months. But look what happens after 3 months. Those on drugs stop getting better, whereas the placebo, the unmedicated group, continues to get better. This was a study done by the NIMH. It was meant to prove that drug plus exercise would be cumulative in its benefit. So you have Zoloft alone, you have Zoloft plus exercise alone. It was an elderly population. This actually is really good, these remission rates. These are really good remission rates at the end of 16 weeks. But then watch what happens. If you're on drug, whether you on drug alone or exercise, this was the percentage who relapsed during the next 6 months. Look at the percentage who relaxed among those who got better on exercise alone. You see this? Very few relapsed. So it was a more sustained recovery. And by the end of 10 months, the exercise alone group was much less likely to still be depressed. This was a study in the Netherlands. They looked at patients who got better on drug. Then they looked at, over the next 2 years, those who stayed on antidepressants, those who went on and off, and those who just stopped taking antidepressants during this time. And basically it was the non-drug group that was more likely. These are relapse rates. So 60% of those continuing on drug relapsed, where those who didn't take drugs, only 26%. So read this. I'm going through this literature really fast, but just read this. This is by a mainstream researcher, Raphael Malik. He used to be a mood disorders expert for Eli Lilly, and he's looking at this research and he's saying, what's going on? What he's saying is, based on this research, if you take these drugs for long enough, you may become chronically depressed. Okay? And then if you continue to read this, he says this. He says, it's probably due to this compensatory adaptation to the drug. So in SSRI, what does it do? It ups serotonergic activity, that your brain trying to maintain normal functioning. It goes down into a low serotonergic state. You reduce the density of your serotonergic receptors. He and other researchers say the brain is trying to maintain a homeostatic equilibrium, its normal functioning. Again, so the antidepressant is acting as an accelerator. Your brain puts down the brake. And what he's saying, over time, even if you stay on the drug, it seems like now, with your brain in this same state, this state, you tend to become dysphoric. By the way, the word dysphoric is a little different than depressed. Dysphoric means I don't care. And it's really like an inability to maintain, sustain an emotional response. In this paper, he also says something that is quite tragic. He says, after this develops, you may not be able to come off these drugs because the brain may not reset. So you may drive the person into a chronic dysphoric state where they can't get off the drugs. These are just disability numbers. This is a look at Canadians who went on short-term disability. They were working. They had a depressive episode. They're going to go on short-term disability. And then they're going to look at those who return to work, those who go on long-term disability. And they're going to assess whether the return to work is higher for those who get treated who take a drug or who refuse to take an antidepressant. And you'll see, once again, the long-term disability rate was twice as high for those who got treated with an antidepressant. This is a long 6-year study in the National Institute of Mental Health. They just looked at those who got treated for their depression and then others who refused treatment, didn't come in for a treatment. You'll see that the percentage who lost their normal role function, that means their jobs, etc., 3 times higher for the medicated group, 7 times more likely to go on disability. So all this data, and I know I'm really jumping around here, all this data is telling you, both for the antipsychotics and the antidepressants, is that over time, it doesn't mean nobody does well, but over time you're increasing the likelihood you'll become chronic. But it doesn't mean that's the case for everybody, right? It's just an odds ratio. Now, the other thing you see with antidepressants is the risk that you'll have a manic episode. Your character, she didn't have a manic, well, she worsened after she went on an antidepressant in your movie, right? Whether it's manic or not, but one of the real risks is that you'll turn manic. And this was a large study of 87,000 patients who get diagnosed with anxiety or non-bipolar mood disorders, basically depression. And then they looked at those who were either treated with an antidepressant or not treated, and they looked at the numbers that converted to a bipolar diagnosis, and it was double for those who got treated with an antidepressant. You remember the doctor in the movie said, well, we don't know if it would have happened or not. In a way, he's right about that, because there were some people not exposed to an antidepressant that went from a diagnosis of anxiety to bipolar. But what this shows is that you double the risk of that happening with exposure to the antidepressants. And if you do a number needed to harm, in other words, you look basically with these numbers, 1 out of every 23 people is going to treated with an antidepressant is now going to worsen, convert to a bipolar diagnosis, and they wouldn't have otherwise done that. This just shows the increase in bipolar diagnoses once we got the use of SSRIs. All right, one of the things I did is look at the adult population, look at remember when I said the prevalence of these mood disorders didn't change over time? Between, in this case, 1991 to 2002? The prevalence in the society is still about 30%. The difference is more people were getting treated, and now look at what happens to the number of people on disability. So the prevalence is no different, the sort of background prevalence of mood problems. What changes between this 1991 and 2002, this is when antidepressant use goes up, is the number of people who are now taking antidepressants for it, and you see this basically, this extraordinary increase in the number of disability, and you see the increase in the disability rate. I know I've really jumped around on this. Here's the bottom line with this worry. We have data from various types of studies that certainly have a strong indication that with this form of treatment over the long term, you're going to increase the risk that a person will become chronically symptomatic, and you're also going to increase the risk that you're going to take a milder problem and convert to a more severe problem. That's moving from depression to bipolar. And this doesn't get into the public domain, but as researchers look at this, they're trying to say, why does this happen? And one of the explanations, I'm not sure this is the only explanation, is this. It's the fact that the drugs stir this opposite effect. So you go on an antipsychotic, it blocks dopamine, that causes your brain to accelerate dopamine. You go on an antidepressant, which increases serotonin, your brain now has to do the opposite reaction. And so so what were we told was the cause of depression? Low serotonin, right? That's what we all heard. What happens, he's saying, is you go on an antidepressant, it creates a low serotonin state physiologically in your brain. That's the worry here. And he's saying this could be a universal thing with psychiatric drugs. They produce processes that are the opposite of what the medication originally produced. In other words, you take an antidepressant, originally up your serotonergic activity. Long term, it causes it to go into a subsensitive state. This may cause a worsening of the illness, continue for a period of time after discontinuation of the medication, and may not be reversible. So the worry is out there now, is can your brain reset after a long time on these drugs? Clearly, many people can. You saw it in your character. But sometimes it seems really difficult to reset. And as I told you, I just came from a conference in Gothenburg about withdrawal, about the hazards of withdrawal. And one of the things we're seeing with withdrawal from antidepressants, people are off the drugs, but they have these prolonged periods of withdrawal symptoms and odd things happening to them, which is a sign that something's gone wrong, with your architecture, inside of your sort of physiology of your brain. Okay, I told you, new paper out in BMJ, evidence-based medicine. And so they looked at the risks and benefits in the literature for antidepressants, and here's the conclusion. Antidepressants should not be used for adults with major depressive disorder before valid evidence has shown that the potential beneficial effect outweigh the harmful effects. Their conclusion in British medical journals, do not prescribe these drugs. And the reason, if you follow the logic here, is they seem to have minimal beneficial effect on depressive symptoms, even over the short term, and there's all these hazards, including being unable to get off the drugs. And if you read the paper, they say there is absolutely no evidence that antidepressants are effective over the long term. So I don't know what percent of your population is on antidepressants, 10%? Okay. If this paper is right, you have 10% of your population taking a drug likely to do harm, and without an evidence base for doing so. So we've gone from 1987, when Prozac was seen as a wonder drug, a miracle drug, make you better than well, to now to here we are in 2019, and this group of researchers are saying there's no evidence that shows even over the short time they really provide a benefit. All right, I have no idea how long I went on. Thanks very much. I just want to say, if you want to know what the state is about, watch your movie again. Thanks.